I'd like to just introduce Dr. Czachי Prid from מכון Dvir. He's been kind enough to sit on our board since the beginning of the creation of the NEABPD, and he's also been kind enough to come this evening to let us in to the secrets behind the running of a DBT clinic. I apologize to everybody for the amount of time it's taken us for us to get started. I guess you could say good things come to those who wait, at least those who wait in patience. Now, if you're just making yourself angry and angry about how long I'm talking, then that's probably not very effective. So thank you to Ruchi and Orit and everybody else's patience. And Czachí Prid, please.
Okay, thank you very much, Meshulam. Thank you for having me, and thank you everybody for joining us this evening. My name is Czachí Prid, and I'm the clinical director of a place called מכון Dvir. I'll tell you a little bit about it, a little bit about how we came into existence, and I'll give you a little bit of insight into behind the scenes of how we run, which is the title of the talk tonight. So מכון Dvir started in 2016 by a dear friend and colleague of mine, Dr. Shmuel Harris, and myself. Both of us, he's a psychiatrist, I'm a psychologist. We were both in private practice. And we saw that we were both dealing with some really difficult cases. And it was difficult. We did a good job bouncing off one another and cross-referring and being in touch. But we realized that we really need a place where we can bring together a really high-quality team of clinicians to really take a team collaborative approach when dealing with these kinds of cases, and to have a place where people facing real difficult challenges can go and have a team deal with them in cases where very often individual clinicians don't really want to deal privately with these cases. So I'm going to go ahead and share my screen. Second. Okay, so we're going to go behind the scenes at our clinic, and we're going to take a look at how we work things. Now, the title is Behind the Scenes at a DBT Clinic. And in a moment, I'll explain to you why we call it a DBT clinic and why it's not really a DBT clinic. And there's a dialectic there, which I guess speaks to how DBT we are. Okay, so מכון Dvir, we are an English-speaking psychotherapy clinic. All of our work is done in English, and we specialize in what we call high-risk and difficult-to-treat populations. And there are a spectrum of personality disorders, other disorders that are not personality disorders, complex trauma cases, and we take a collaborative team approach to all the things that we deal with. Now, initially, we were a strictly DBT clinic, and when we were a small team, it worked for us, and we had a small caseload, it worked for us. At some point, we realized that not every person coming in is appropriate for DBT. Not everybody is interested in DBT. And if we really want to be a good interest for our entire client base, we really want to be, our entire client base, we need to expand our approach. So we still primarily use DBT. Also, in terms of our treatment philosophy, we very much use DBT principles. We bring in CBT as well. Many of our staff are trained in schemotherapy. Motivational interviewing is not a therapy modality, but it's a style of work that we've really found very helpful, and we've integrated into a lot of what we do. And it's necessary, especially when working with clients who struggle with their motivation and commitment to therapy. And then there are psychodynamic elements that we'll bring in as well, where appropriate for certain clients. Our Jerusalem branch is our main location. We started up in 2016. Over there, we offer a standard DBT outpatient therapy as well as skill groups. We have 1 psychiatrist on staff and 7 clinicians. Our Ra'anana branch, we started last year, and that's where we have our intensive outpatient program, which I'll talk about in a little bit. That's been running for about a year, and there's individual outpatient therapy there. We have 1 psychiatrist and 3 clinicians in Ra'anana. So I'll start with the intake process. And usually clients come to us from a number of places, either from the community or a Rav or a teacher or a mentor or other therapists who want to refer cases on to a place where they feel like they need a bit more than what they can offer, or other psychiatrists. And at the initial meeting, at the intake, we start with an essential question for the team that we ask ourselves during the intake is, how can we help this person? And the question that the client is looking to answer is, am I going to feel comfortable here? Do I want to give these people a shot? Do I want to trust them with my care? And those are the basic questions that have to be answered at that first meeting. On our end, what we attempt to do is we get initial details before the person comes about who the person is. We try to take a guess who the best match would be for this person in terms of clinician, and we try to assign them the intake. Obviously, that doesn't always work. We don't always take a good guess, but we do try. And what we do is we make it very clear to the client who comes that coming in for an intake doesn't mean that you're accepted for treatment, because in order to really take you on and accept you for treatment, we need to first go through this process and really see if we think we can help you, and how we can help you, because we don't want to just take cases on if they're not going to be really appropriate. Okay, so the first set of questions, the first set of questions that we ask in the intake have to do with the history of symptoms of this person, with what they're struggling with, when it started, how it started, what's going on right now. We want to know about the social history and the family history of the person, and really any other pieces of the history that would be helpful. And the goal over here is for us to have a conceptualization of how the problem may have started, how it developed over time, and how it evolved over time. How did it change based on the way the circumstances of the person's life changed? The other thing that we want to know is, what are the systems that maintain the problem? Meaning, how does the person structure their own internal world in terms of how they think, how they feel, what they're doing that helps keep this problem going. And we also want to look at the external systems outside of the person, meaning if we take a look at the kinds of behaviors that this person brings into the world, the way they interact with their environment around them, what happens there that keeps the problem going? And we also want to come out with a solid understanding of how this problem impacts the person's life. And the reason why those issues are so important is because it sets us up to really be able to identify and define the problem in a way that the person really gets on board with what it is that they're struggling with and what they want to address in therapy, and in a way that we can set up for, well, if this is how you and I both understand the problem, how it started, how it's developed, and what's keeping it going now, then maybe we can also agree on what we're going to do in therapy. And in this way, already from the beginning, we're starting to build the client's sense of motivation and engagement in therapy. The other things we want to look at for the intake are things like treatment history. What does this person's previous treatment look like? When do they start getting help? How many therapists have they been to? Have they ever been to a higher level of care? What was their whole life trajectory? What kind of treatment did they have in the past? We want to know about their risk history. Have they ever been at risk to themselves or others? If so, in what way? Any suicide attempts? Have they ever gotten close to a suicide attempt? how do they self-injure themselves, and how badly do they do it? And we also want to get an assessment of their goals and motivation. And this is the conversation goes in the way of us asking questions to figure out, okay, what is it that this person really wants from therapy? What are they looking for? And over here it gets a little tricky, because very often a trap that therapists can fall into is we hear the client talk about the problem, and then where we go automatically is, if this is the problem, then this is probably where he wants to go, just because it makes sense to us that anybody would want to get better in this way. But that's not necessarily true. Sometimes the agendas don't really align, and we want to make really sure that at the end of the intake, we understand what they're looking for, even if it doesn't match what we think might be a good idea. And we also want to get a sense of how motivated they are to work toward this goal, and what are the things that motivate them? Why do they want to change? All of these things are things that we use to build into the treatment plan. So to get into some of the specific questions that we're looking for, what level of risk is this client, and can we care for that in an outpatient setting? Can we provide the kind of care that this person needs to really manage the level of risk that they bring in? What can we anticipate as far as how they're going to act in therapy and what their attitude is going to be in therapy? And this sometimes you can see from the history of treatment. If a person has been through 5 or 6 different therapists in a 3 or 4 year span, so it could be that they just hadn't met the right therapist or the right modality, but it's very likely also that there's a way that this person relates to therapy in terms of their expectations, in terms of the behavior that they bring to therapy, that we probably have to pay attention to and address, or we're just going to be therapist number 7. To what extent is a client a ready and willing participant in treatment? And genuinely ready and willing. Sometimes people will come in on intake and they'll present as if they really, really want to get better and they're super motivated. But that doesn't necessarily mean, it doesn't translate into them really, truly being fully engaged in therapy. So we really want to try and figure that out as much as we can on the intake. To what extent is the client motivated to make changes, and what factors increase or decrease motivation? So part of looking at the history, and especially the treatment history, is we're keeping an ear out for what are the things that change in your life that make you more likely to want to change and to work on these problems, and what are the things that kind of take you away from that. And overall, the goal is how much time is likely to be spent in pre-treatment. For anyone without a DBT background who doesn't recognize that word, pre-treatment just basically means a period of time in treatment where we're not necessarily doing the work of behavior change. We're building up a joint conceptualization, an alliance, and the client's motivation in order to start that work. Okay, and so here's something that we taken with us, an important dialectic when we're talking to the client about their history. Number one, an important rule to keep in mind is that the best predictor of future behavior is past behavior, right? So if we get a sense of a history of years and decades of this client's behavior and this client's approach to therapy, so it's reasonable to assume that we're probably going to see more of the same, just because that's how human nature is. And at the same time, it's also really important for us to hold on to the idea that people are capable of growth and change. That just because a person has a certain history, it doesn't sentence them to continuing that same set of behaviors forever. People are capable of growth and change. People can be motivated, and we want to hold on to both of these things so that on the one hand, we don't go into this therapy blind, and we can anticipate ahead of time what we might encounter in order to better help them. And we want to bring in a sense of hope and belief that people can get better. And we do want to give people the benefit of the doubt and to really help them get to where they need to go. Okay, so one part of the intake is the meeting with the therapist. Another really important part of the intake is having a conversation with the previous treatment professional. Even if it was the therapist who saw them a bunch of years ago, we really want to make sure that we talk to the previous therapist to really help us get a full sense of who this client is, what we can expect from working with them. We want to especially know from the therapist if there was something that really didn't work that we should watch out for, or if there was something that was really helpful in their work that we should know. In general, getting this kind of report is really, really invaluable. Sometimes the therapist can give us information that we would never have guessed from just having a conversation with the client. In certain cases, we'll speak to relevant collaterals. We might speak to a spouse, we might speak to a parent, we might speak to teachers. This is really case dependent because we don't always do that, but in some cases we might decide that really, in order to get the full picture of the client, we would go ahead and do that. And of course, it goes without saying that all of this is with the client's consent. In addition to having those conversations, there are a whole bunch of measures or questionnaires or tests that we'll give the client to do in order to really help us round out the picture. One is called the PID-5, which is a personality. It's an overall picture of different personality traits that this person has. We have a questionnaire about acute anxiety and depression. We want to take a look at how that's motivating them. Anger and aggression, to what extent this person experiences it. Dissociation, does this person ever feel detached from reality in any kind of way? Is it possible that there's a trauma piece here? We want to look at self-injury to also help us assess risk. We want to look at the person's relationship style, both in terms of getting some diagnostic data and trying to figure out an overall conceptualization of the person, and also to help us get a little bit more of an insight into what our relationship is going to look like. We have a few borderline personality disorder questionnaires because it's a diagnosis that we see a lot of in our clinic. So we really want to get a good sense of what's going on there. And in general, these are also really helpful measures to have because they give really good, interesting information about the client. And then finally, a scale of emotion dysregulation to get a sense of numerically how dysregulated does this person tend to get. Okay, so that's in a nutshell how we do the intake. Some of the challenges that come up very often when we do the intake is that the client comes to us because they've been referred for DBT, they've been told, oh, go to מכון Dvir, but they also want to continue with their old therapist at the same time. And that really doesn't work. We experimented with this early on, and we've learned our lesson that it really, really doesn't work. And that's for two reasons. Number one, there are two different models of how a person understands themselves that are competing with one another. There's ours and there's the other therapist. There's two different works. And when that happens, motivation and alliance on the goals with us goes down, and it doesn't really work so well. The other reason is that it's very hard to really build a close relationship with one therapist when you've got another therapist also. There can be a competition there. So it's never really worked out for us. Another challenge has been when the client wants to keep their individual therapists that they have now, and they only want to come to us for skills group. maybe their current therapist wants to add on a skills group because they feel like it'll help the therapy that they're doing now, or the client thinks that it would be helpful for them to have a skills group. And for a long time, this is something that we did until we realized there's such a significant difference between the clients who are with us, doing therapy with us, and also doing the group with us, versus clients that are doing their individual therapy outside with a different therapist and doing group with us. We found that the clients who were working with outside therapists, they weren't practicing the skills as often. They weren't as motivated to do the skills, and there was a higher dropout rate in general for those groups. And so what we ended up doing recently was that we have two groups running. We have a regular full skills group that goes, I think, 25 or 26 weeks, that covers all of the DBT skill modules. And that's for the clients who are being treated by us in the clinic. And then we have another group. It's a 12-week group that goes through the basic skills. It's a closed group, so you start and you end the 12 weeks with the same people. And that group is specific for people who want to work with an outside therapist. So far, we found it more useful because it's a shorter group, so it can be closed. There's more of a tight-knit, secure group feeling, which motivates people to stay in the group. Because it's shorter, there's a shorter commitment involved. And well, we hope people continue practicing the skills afterwards so they don't lose them. Another challenge that we have often is when the client is not really that motivated, but the family is very, very motivated for the client to get treatment. And sometimes that creates a situation where the client ends up saying the things that they need to say to be in treatment, but they're not really there. They're not really engaged and involved, and it's hard to really work with them. And sometimes our first clue to this is that the family member calls to make the appointment for their spouse, child, parent, whatever it is. And so what we've started doing is the office started insisting that the client interested in therapy really needs to make the call for themselves, because that really turns out to be a major predictor of how motivated the client will be. And very often this can get really tricky because sometimes we'll do an intake and we'll have, based on all this information that we get, we have a certain treatment in mind, whether it's a kind of treatment that we would like to provide for the client, or whether it's a certain recommendation outside of our clinic that we want to make for the client. And it gets tricky when the family of the client really pushes back and really wants to get the client in treatment with us in the kind of treatment that they want. Pretty much in every case where we've said, okay, let's try this, let's take the case on and just see what happens, it's never worked. I think 95% of the time it never worked. We've learned to really trust our intuition as a team, and we do try hard to engage the families at the beginning, and really try and work with them to get them the help they need. Hopefully sometimes it works, sometimes it does not work. Okay. Guiding principles, and you'll have to forgive me, I added another slide to this, so it may not have been translated, but we'll do the best we can, I guess. So our main guiding principle comes from the DBT world, and that's the principle of consultation to the client. And what consultation to the client says is that this is the client's treatment. People who are in treatment are here because they're here voluntarily. It needs to be that way. They're here because they want to be here and they own the therapy. And so to us, our relationship to the client is we're just a consultant. We're not here to make the goals for them. We're not here to put in our agenda and direct them and tell them what to do. We're just the consultant. They'll, set the goals. We'll help them set the goals. We'll do it collaboratively with them, and we'll work with them to help them reach their goals because that's what they want. They want us to help them get to their goals. It also means that we are not consultants of anybody else, meaning we are not the consultants of the school that's sending the client there and who might have an agenda for what they want for the client, but it's not their treatment. It's the client's treatment. We're the consultants of the client. And what this does is it puts a lot of emphasis on building an alliance with the client on the rationale for treatment, why they're in treatment, and what their goals are. And when we have that in place, that is a big predictor of successful treatment. When that falls apart, treatment very often just stops because we're just running around in circles and we don't really have an agreement on what we're doing here. And so it's really important to have that defined problem, the defined goal, and to have it agreed on by the client and the therapist. Both the client and the therapist create the agenda, meaning it's not us saying, okay, here's what we're going to do in therapy and kind of instructing them, because then that's us. We're not being a consultant to them. It's also not just the client running the whole show, and kind of telling us what they want, which is great when it would work, when it's something effective. But if it's not effective, well, you brought us in to consult with us, so it's got to be this joint process. At the core of this is that we see the client as having what we call self-agency, being somebody capable of directing treatment, somebody capable of making mistakes and rising from those mistakes and really taking ownership of the therapy. We really avoid as much as we can fragilizing the client, which means seeing the client as something very, very fragile that we have to be careful with. We have to handle with kid gloves, walk on eggshells, really be very careful. We assume that they are capable of handling the therapy. The other guiding principle that we have is this idea of checking in, right? What a certain trap that we can fall into in therapy is autopilot. Because we're human and we get into habits and we get into patterns, and the most natural thing for a human being to do is to do what they're just used to doing. And so a trap that you can fall into in therapy is to kind of just have a status quo. You come in, we talk about this and we talk about that. It's really, really important for us to check in. Are we doing a good job? Are we staying true to the goals? Are we staying true to the rationales? And if we're moving away from it, then do we have a good reason for doing that? And so what we do is 3 or 4 times a year, we really try to check in with the clients and say, okay, since last time we checked in or since intake, what progress have we made? What have we seen change in your life? What changes have you made? And then we go back to, okay, what would you say we're working on? Again, let's review. What are the problems that we're working on? What are the goals that we're working toward? And how do we know if we're making progress? How would we measure that? Checking in with those things is really, really important because it keeps us on the path of doing the job that we're supposed to be doing, staying true to our job and staying true to the client, and helping the client stay honest with themselves and their own values and goals for what they came into therapy. And so part of this is us checking in with ourselves as therapists. Part of it is also checking in with the client in terms of not just the goal and progress, but the whole experience. What's been helpful to you? What hasn't been helpful? What do you think of our relationship? These things are really important to keep in mind because if therapy is not a positive experience for the client, they're going to drop out. It's very, very hard to maintain that commitment and that motivation. So it really has to be something, therapy has to be something that the client feels is relevant to them, is important to them, and is a rewarding experience. Okay, I'm going to shift a little bit and talk about our treatment team meetings, what those are and how they go. So the idea over here is that once a week, the entire clinical team meets to discuss what's going on in the clinic, to discuss their cases. And there's a really important dialectical principle that we hold on to in these meetings, which are there are multiple valid perspectives regarding clients, problems, and clinical situations. Right? We have a tendency, we see it in one way. We have our perspective that's informed by our history and our experience, and that's how we see it. And the big advantage of treatment team meetings is that we get to hear other perspectives, not that we're more right than other people or that other people are more right than us, but it gives us a chance to get a fuller picture by getting multiple perspectives and multiple sources of feedback. We try to keep the idea is to keep our bias to a minimum because we're getting multiple sources of feedback, multiple comments and reactions on the cases and the material we bring, because not everybody has met every client, not everybody has what to do with every client, and so there are other clinicians who can really hear the case and approach it from more of a blank slate, so to speak. Clinical decisions are made as a team. That's very, very important. It's important for clinicians to know that other clinicians have their back and are supportive to them, and that they can, they're not dealing with this case alone. And that's important because, especially when dealing with difficult cases, when clinicians feel calm and safe and supported, they're able to regulate better, their anxiety goes down, and that just makes them a better clinician, and they do better by their clients. Another important element of the treatment team meeting is that we really try to flatten the hierarchy, meaning it doesn't matter whether you're a first-year clinical intern or you're the clinical director or you're the psychiatrist, your opinion is important, and we want to hear from you because you might have something to say that maybe nobody else thought of. And we really, it's really important for us, not just educationally, but clinically, for it to be the kind of environment where anybody can say whatever their perspective is and whatever's on their mind. And in general, it's not just about having other perspectives, but it's also other roles. So, for example, when you have the client's therapist and their group skills group leader and their skills coach and the psychiatrist all come together to discuss the case, you get a much more full and accurate picture of what's happening here. And so that's really important. All right, here are some of the dialectical assumptions and the principles that we bring into our team meeting and that we hold on to, not just in our team meeting, but also in the work that we do with clients. Number one, people are doing their best. Clients and clinicians are doing their best. You may have heard this as one of the DBT dialectical assumptions, but the idea over here also is that at any given moment where we are, there are so many things operating on the decisions that we make. Our past experience and our goals right now and the mood that we're in. And at any given moment, what we produce is our best work for that moment. And keeping in mind that people are doing their best allows us to be more compassionate to ourselves. It allows us to be more compassionate to our clients. And it creates a much more collaborative environment. At the same time, another principle is that people, clients and clinicians, have to continue working on their skills to be more effective. As a therapist, I have a lot of progress to make. I have a lot to learn. I have a lot of feedback to consider. And I always have to be aiming upward, trying to improve my clinical skill, trying to constantly grow and be a better therapist. And we expect the same of our clients. There is this idea that if you want to reach your goal, it's a matter of constant work. And that's not coming from a punitive place or a critical place. It's just the nature of how things go. Another principle is that people will make mistakes, clients will make mistakes, clinicians will make mistakes. The key is to understand the causes and work to repair the alliance. We really want to continue building the alliance and the relationship and give people second chances. We don't want therapy to fall apart just because, as clinicians, we made a mistake, or because the client made a mistake. We want to understand what's going on, and we want to repair, and that's also the message that we really try to give over to our clients. Another principle: clinicians work most effectively when they observe and respect their limits. So I have to know, as a therapist, when I'm burning out from a case, when I need to limit my involvement, limit my interactions. And sometimes it comes across to our clients as cruel. Why weren't you there for me? Why can't you answer? Why can't you do X, Y, and Z? Sometimes it seems like the therapist is falling short of expectations. And it's really important for us to allow ourselves to do that, because when we don't do that, we burn out and we're not effective in the long term. So it's like running a marathon. Sometimes you're not running your fastest because you're aiming to run the longest. Another really important principle is that clinicians who work with dysregulated clients need support. And that's a really important element, is being able to be a team where we don't only grow our clinical knowledge, but we feel supported. Like I said before, the more we feel supported and safe within our clinical team, the more we're able to really be there to support our clients when they really need help. And finally, like I said, in terms of flattening the hierarchy, there is no such thing as a stupid idea. All ideas are welcome, even if it sounds stupid to you in your head and you feel embarrassed raising it at team meeting. Don't, because it might sound stupid to you, but it's actually like, it might be a jumping off point for a much better idea. So whatever it is, we want you to say it. Okay, how exactly is this structured in a treatment team meeting? So just like a DBT skills group, we start out with a few minutes of mindfulness to help ourselves get grounded. It's a bit of a debouche also for the whole team. We check the agenda from the previous week if there's anything that is left over that we have to follow up on. Then we check in as far as high-risk issues. And a high-risk issue is any situation that involves elevated risk to personal safety of a client. And so the idea over here is to give the clinician a chance to check in with the team for a clinical consultation, just to make sure that we're handling it correctly, and to get support if needed. After that, we'll speak about any new intakes that have come in. The clinician will go over all the information, talk about their meeting with the client, talk about their conversation with the previous treating professional, and also go through the scores on the measures. We'll talk about conceptualization, we'll make a recommendation for treatment, and we'll assign the intake a clinician. And like I mentioned before, usually it's the clinician who did the intake. And then after that, we'll deal with any other clinical issues that come up, or any kinds of questions that any team members have about their clients. The last thing I want to talk about is IOP treatment. We started this program about a year ago. We've learned a lot from it, and I guess I'll just share with you very briefly what it's all about. So the intake process is very, very similar to what I described. The team meeting is also very similar to what I described. In addition, in IOP, there's also a morning check-in. Every morning, the staff has a 20-minute check-in just to discuss how the previous day went with all the clients.
So
the program started.
What IOP stands for?
Oh, sorry. Yes, IOP stands for Intensive Outpatient Program. So outpatient program, intensive. What exactly makes it intensive? I'll tell you. We started with it being an open 12-week program, meaning it's a 12-week long program, and it's open. So every month, new clients can join. We found that this was a little bit too much, and so we changed it. It's now an 8-week program instead, and it's closed, meaning at week 1, whoever's in is in, and that group stays the same for 8 weeks. 8 weeks, the program is over, and new people come in. The program runs 9:30 to 3:30, and we at some point realized it's a little too much. We cut down the hours. It's now 9:30 to 1:30, and it's a program that runs 3 days a week. So 8 weeks for 3 days a week. The clients come in 9:30, and it's a group therapy program that includes DBT skills, art therapy, self-defense, yoga, so a lot of movement-based therapies, as well as DBT, and community process, which is basically a discussion of how things are going between us in relationships. And it really sets up the clients for effectively practicing interpersonal effectiveness skills. And that goes along with one individual weekly therapy session, which is it's an 8-week long program. So it's 8 individual sessions, and each one is directed at helping the person move through the program. Who benefits from this program? So the people that we found benefit the most from this program are people who have been really struggling in their functioning. It's been maybe to a greater extent than in standard individual therapy, and progress is really slow. And so often the intensive program can be a boost for these clients. Another kind of client who benefits that we found is people who've just been in therapy for a very, very long time with slow or no progress. Sometimes the intensive program can be a catalyst to really start to get things moving with them. And for clients who are at a higher risk level, who sometimes individual therapists don't really want to take them on because their level of risk is very high, an IOP might be a better option for them because it can handle a higher level of risk. Advantages of treatment at an IOP. So first of all, what we've seen is that we're at a place where every single day, all day, often, we're talking about DBT skills. And it's not like you're coming in for, an hour and a half group and then, your individual therapy session and that's it. It's a real big chunk of time. And so people start using DBT language and DBT ideas, and it leads to more internalizing the skills and really learning how to use them. Another advantage is that what happens in the social environment is that whatever issues I might be having in my life that I might be struggling with are going to come out in my relationships at the IOP, either my relationships with the staff or with other participants in the program. And so that gives the therapist a really clear view of what's going on, and it allows us to intervene and deal with this program, with the problem as it's happening, which is really, really interesting. And the other thing is that because we're meeting so often and for so long of the day, we really have there's more clinical feedback that the client can get, because it's not just meeting with one therapist, you're also being observed by the psychiatrist and the other therapist that's happening, and you have a whole bunch of therapists working with you. And the work is done much more intensively and it's done much more frequently throughout the day. So like over a 4 or 5 hour period, you have multiple points of therapy contact. What are some disadvantages? So one major disadvantage that we saw is that people need to take a break from other commitments. You can't go to school full time or work full time when you're in the program. So it means you have to be somebody who can take off for a couple of months to get through the program. Another disadvantage is that as much as the work is frequent and intense, it moves very quickly. So we go from, each day, a new skill. And so it really needs to be reviewed, or they lose the gains after, eventually, you stop practicing it and you lose it. And not just with skills, but with therapy also. It means that, you're learning a new set of skills and new ideas in a particular environment. And it's really important to have a good plan in place by discharge in order to really maintain everything and apply everything that you learned in this environment to your old environment. Otherwise, of course, things are going to fall apart. So those are some things to be aware of in terms of the IOP. And that brings me to the end of what I have prepared. I'm happy to take questions if anybody has.
Why don't we give people a minute or two to think about and digest a little bit of what you said? And they can write questions either in the chat, or we can open up the floor to people. I mean, I think one of the things that I sort of picked up from the whole conversation, presentation, really was that you're really thinking about what you're doing, which I think as as family members, who most of us are one way or another, or as patients or potential clients, it's good to hear, right? That the clinicians are thinking about what they're doing, and they're, I mean, I would dare say some of what was concerning as a layperson was when you said, well, we don't know what we're doing either. You didn't say that exactly, but we're experimenting, we're trying, we cut down the hours, we added the hours, we spoke about it. It was a bad idea, but maybe good ideas can come from it, and so on and so forth. So maybe, you could talk to that, because when you go to a mechanic, for your car, you kind of don't say to him, well, why don't you experiment with the carburetor and see what you can do with it?
Yeah, I love that question and that point, because it's so true. And I find myself talking not just to family members about this, but to clients themselves. And I actually use the car metaphor, because people will come in and they'll use a car metaphor. And the reality is that people aren't cars. You have cars, and you can have 1,000 cars, and they're all built the same way, with the same materials, connected in the same way, right? And so there's a certain, standardization there where we know how things work. People are different. People are not cars. And we, as therapists, we can learn general principles, right? And we get really, really good at taking guesses. It sounds really scary, right? But this is how it works when you work with people, all of whom are different and unique human beings. In fact, you wouldn't want to go to a therapist who says, oh, here is my model of how people work, and this is what we're going to do. Why? Because then they're just taking a theoretical model and they're trying to shove the person into the model, and that's not so effective. And so the idea here is we want to get all the information that we can to make as good a call as we can. And we want to continue asking ourselves, okay, is this good? Should we change it? Is this good? Should we change it? And constantly be asking that question in order to do a better and better job.
So
anyone who sells you a story that that they can do otherwise because I have this method that works, that's snake oil.
So that brings us to the next question, which someone asked in the chat right now. Do you have any data on your success rates? I mean, how do you quantify success or qualify success? And do you have any data on success rates?
Yeah, so that's a good question. So number one, the difficulty here is how do you define success? And when you look at studies that are done, treatment outcome studies. So very often they'll take a certain paradigm, right? So they'll say, let's say self-harm, right? And what they're doing is they're taking a standard program and a standard outcome measure, and they're saying, well, how successful are we? What is the rate of reduction in self-harm after this, this kind of client is given this kind of program? And that's really helpful information to know for the mental health community. That's great. The difficulty is when you're not just dealing with one kind of client that you're running through a program, you're dealing with a very wide range of clients. And you're not just dealing with one way of working with a client, you're dealing with each client being adjusting the treatment for each client as it is. Each client is a little bit different in what they bring in, and what success looks like for each client is different. And so this is one area where we struggled, is how do we measure success in a reliable way? And there really is no way to measure success in a reliable way. And that's answer number one. Answer number two is a little bit different, which is, remember I listed those intake measures at the beginning, all those measures that we take. So initially the plan was, okay, we're going to repeat those measures every 3 months, right? We're really going to do this. And our therapists that we have are really good clinicians. I can really vouch for each and every one of them. They're experts, and you know, all their expertise is compounded because we all talk to one another. What they're really, really bad at is following up on the measures and bugging the clients to do the measures. And one reason why they're bad at it is not just because they forget, but it's because the clients don't really want to do those measures because they're long and annoying and boring. And it's like, well, you guys want this to know our progress. I don't really care. So they're not going to do it. And it's kind of low naive to just keep it, okay, did you do it? Did you do it? Did you do it? So over the years, we haven't really been so successful in collecting that data. And that's also part of the reason why we do these check-ins, because we do it on a more individual level. Each client looking at it how it is and asking the question, are we making progress? Right? It's not like, are we successful? Right? None of us are ever going to be, you know, perfect human beings, but have we gone from here to here? Right? How are we getting better? And I think that's the really critical question here, more than success rate, which is a little harder to define.
Well, so it's interesting because Maria Zanarini has done a 20+ year study on a longitudinal study on people with BPD at Harvard, and so she defines, right, as I'm sure you know, right, hafuga, right, where the acute symptoms seem to have gone away, and then even hachlama, which she refers to as, you know, as actually getting better, having 2 good years of intimacy or 2 good years of working or studying, whatever the case may be at that time of life.
Right.
So I mean, I wonder,
when you're in a research institution and you're built for this kind of work, and you've got 20 years of data in an aggregate, you know, then you can do something like this. מכון Dvir is not set up for that. Right.
Fair enough. No, fair enough. So, and I won't push you on that. So there's people have also asked, okay, so you talk about treating complex cases and perhaps cases where there was dissociation, other trauma, perhaps symptomatology. So do you work with people who have DID? That was
we have worked with people with DID. We haven't worked with.
Sorry, DID is what used to be called multiple personality disorder. Yeah.
Right. We have worked with people with DID. Very often, and I think this is the case in general with people with DID, it generally goes undetected on intake, and it's only over the course of treatment at some point that it's uncovered that this person is really struggling with DID. So we haven't had a ton of cases, but off the top of my head, I can think of a whole bunch that we have worked with.
Okay, and so Sophia asked, how do you deal with the fact that patients who have borderline personality disorder oftentimes slam the door in your face? Maybe you could, hone that. You've talked about it here and there over the course of the lecture, but when they slam the door in your face, what do you do? Bottom line.
Slam the door in my face and sort of like end treatment.
Walk out of therapy. I think that's the idea.
Walk out of the session.
Walk out on the session. Walk out on therapy itself. Walk out on the therapeutic alliance with you. Interfere with therapy continuing.
Yeah. So, okay. I would say it definitely happens that people get really, really upset and will express that anger in all kinds of ways. Some, it might be that they walk out of the room, slam the door, and okay, they quit the session. It usually doesn't mean that they're leaving therapy. Generally in that moment, like, okay, session's over. They're angry. They left the session, so the session's finished. I'll see you next week. Where they leave therapy, it really depends. Usually it just doesn't come out of nowhere that we have a great alliance and 5 minutes later, like, you're leaving therapy and you're actually never coming back. That usually doesn't happen. Usually there's a buildup and there's a slow disintegration of the alliance. And so usually we try to pick up on that before it happens and re-solidify the alliance.
So I'm going to take advantage of the fact that I'm asking the questions here.
Yeah.
I'm going to say, you very clearly showed us, right, what intake is and how you think through things. And then there are cases which are just not, cases that you think are going to be very successful for you to deal with, whether it's the individual, whether it's their background, whether it's where they are right now, and so on and so forth. And on the one hand, yeah, I mean, if you if I bring my car in and you can't repair the motor, and you say, well, I can't really repair the motor, so I'd say, okay, maybe I should get a new motor, right? But when it's my kid or my spouse or my loved one, and I bring him in and you say, well, you can't really help. It doesn't, obviously that's very, very difficult for the family members because they're desperately looking for help. You're the experts. So how do you deal with that? How can it be dealt with better?
Yeah. What we usually try to do as much as we possibly can, and I think this is important, is say, look, we don't think that we're the right setting. Here's why. Here are some next steps for you. So it's not just a no, because that's not helpful. It's a no, do this. Some kind of recommendation, even if it's another number to call, because it doesn't really feel good. For us also to just say no, period. That generally, very, very rarely would that happen. So we do try to direct people somewhere. And like I said, there are times where we've really known, like with all of our clinical intuition based on the intake, that this is not an appropriate case for us. And yet, because the family is so desperate, or because the idea of a higher level of care really scares them, or just the case that comes to mind right now is where I trust Mahon Vir to keep it secret, but I know if I call this other person, then there's a chance that somebody's going to find out, concerned about shidduchim, whatever, and so they're pushing us to take it, and it's a mistake. Not only is it a waste of time and money for us to take it, but it adds to that client another experience of, see, they couldn't help me. So it's never a good idea.
Right. So it's the client's advantage.
And at the same time, there's really a lot of empathy that we can have for families and for clients who are really desperate to get help, 100%.
Right. So bottom line, it's communicating somehow that we'd love to help you, and it's best for you not to come here right now, and we would suggest that you try X or Y. That might be helpful.
Right.
Okay. We have a bunch of other questions here. So someone asked whether they can work with the previous treatment provider. That you've already really answered in the course of your discussion. So the person who asked can go back and read the notes. So someone asked whether there are cases where you're not sure what the diagnosis is. Maybe you can elaborate on that a little bit. They specifically asked about borderline or schizophrenia.
Borderline or where we're not sure if it's borderline or schizophrenia?
Right, correct.
Right. So we're not. I I would say in most cases, we're not really set up to treat schizophrenia. I would say so that would be a really important rule out. Generally, oh, this is a detail that I forgot to mention. Where there's part of the intake where either there's a need to further assess diagnostically, or where there's a risk issue or anything else where it would be relevant, a meeting with the psychiatrist is also a part of the intake, even if the person already saw an outside psychiatrist. But I'll take that back. In many cases where a person has just seen an outside psychiatrist who is somebody who can be in contact with us and be a good teammate, so we'll be in touch with the psychiatrist. Where they haven't, or where they've seen a psychiatrist who can't really be a teammate of ours, as happens very often with psychiatrists through the Kupa, we'll have them see our psychiatrist. The idea being there really needs to be a very close contact between the treatment team.
Okay, that makes sense. So just a couple more questions, and then we'll thank you very much for the time that you've given us and let you get a well-needed rest. So someone asked here, just do you treat? I mean, I guess let me rephrase it. Do you treat really high-risk patients? She asks whether you treat people who have suicidal ideation, let's say, but let's even knock it up a notch. Are there patients who are too risky or at risk for you to treat, and what would you do in a case like that?
Yeah, there certainly. There are in outpatient treatment at Mahon if somebody has a history of suicidality, but they are not currently it's hard for me to answer that question because it's a very case-specific question. Whenever you do a risk assessment, there are all sorts of risk factors and protective factors that you have to assess. So it's really individualized. So it's hard for me to give a specific answer. I will say that very often we'll take on cases with a higher level of risk where the person is engaged in treatment, meaning where the person could say, I'm not suicidal right now. Here are the reasons why I'm not suicidal right now. I'm interested in treatment, and I want to get better. And we believe that we can form an alliance with this person, and we have a safety plan in place. Then we would take them on. With that, there are cases where we have said, look, you are too high risk for us, and this is not an appropriate level of care for you.
Okay. And then last question. Well, so people have asked about how, I guess kind of the question is, how do we contact you and how do we begin the process with you and how much does it cost? Those are kind of more bureaucratic questions. Maybe you can talk to them for a second.
Okay. So if to get in touch with us, you can call us, go to mahonvir.org. I can also just say the number real quick over here. It's Mahonvir is 02-625-2527. That's 02-625-2527. That's the Jerusalem office number. You can also look us up online and email us. That's a good way to get in touch with us. In terms of cost, there's a range depending on which therapist it is, and also depending on if it includes group, either the longer group or the shorter group. So that's probably a better question for the secretary.
Okay. I put it into the chat, but unfortunately, I only went to one person. So I'll try to get that further on the chat, or I'll send it to the WhatsApp group. That's probably a better idea. Okay. Last question. So this is okay. So individuals who might come to you, and you spoke to this a little bit, who don't believe they need treatment. Are there certain ways of speaking with people who just really believe that they don't need treatment and there's nothing wrong with them? Either within your treatment provision or just speaking to the general public here. What can they do at home?
Okay. Wow, that's a great question. That's a great question. That's not an answer. That's a lecture. Okay. I'll say like this. The one of the things that we'll do at the intake, and this will take from motivational interviewing, is really get a sense from the person of what they want. And here we try to be really good salesmen. A good salesman will sell you something that you never realized you needed, but they'll tell you why you need it. So the idea here is to really hear them out, really give a sense that we don't have any agenda. Consultation with the client, right? We're here, for you. You tell us what you're looking for. That sometimes that kind of approach, I'm speaking in very, very general terms here, can lower their resistance, can help them feel like, okay, this person's not forcing me. And that can foster a conversation where not that they'll say, yeah, I really do have a problem, but ambivalence will come out, right? Maybe there's a part of me that sees a problem, but I'm not sure. Maybe I need help, but maybe just for this, or maybe not. And once you start with that conversation, you can go further and see where it goes. We've had situations where we've had a bunch of conversation. The idea is, you'll come to therapy, and therapy will just be we'll just have 5 sessions and we'll try to figure out if you need therapy, and that's our thing. We'll do 5 sessions, and could be at the end of 5 sessions, we'll say, goodbye and good luck. Or you'll come into therapy, who knows? But it does happen that people will come in and they'll say, yeah, I'm only here because my wife wanted me to come, but I think she's nuts. She needs help, not me. And in that case, okay, so if you don't need help, you don't need help. But usually we try to identify those cases before they come in, so we don't waste their time and money. And we'll only see somebody if they're open to having a conversation.
Right. So, I think I should point out, people oftentimes will say, oh, these clinicians are money grubbing and they just want to get more clients and make more money off of me. Sure, there are clinicians like that, but at least you've certainly given us an example of a clinician who cares and is making plenty of money, with all the people who are coming into your clinic. And what you want to do is help the people who you're actually working with, and not just, take their money. And also, not take money from people who you're not going to be able to help, or you don't see as likely candidates for your help, which is again a lovely thing to see. I just a word on motivational interviewing for those who don't know about it. And when Marsha Linehan developed DBT, she basically read every self-help book, every book about religion, every book about psychology, psychiatry, etc., that was around in the 1960s America. And you can imagine there was a lot of stuff there in the 60s and the 70s in the States. And one of the things she did steal a lot of good stuff from was motivational interviewing, which was in its infancy then. So if you're using it, you're absolutely true to DBT and to Marsha's approach to that. And again, and really her love for, if it works, use it. So definitely in that sense also, DBT is really about being effective. So I really want to thank you for being here this evening.
Thank you.
Being very effective. Bearing with our 40 minutes of mindfulness practice and trying to get into get everything working. And also letting us sort of see under the hood of מכון and about how therapists are thinking and how they're acting. And we look forward to continuing the conversation. And if anybody has, other questions they want to send me, they can do that. We'll leave the WhatsApp group open for this evening's talk, and you could send things there. And good evening and God bless.
Yeah, thank you for having me, and thank you everybody for joining.
My pleasure.
Yeah. All right.
Thank you.
Okay, take care, everybody.